Thank you very much. And thank you for the invitation, Julio. I thought when I was invited, I had the analogy of being invited to a Chevrolet sales meeting where all the sales representatives are in the meeting, and I'm invited to explain to you why you should really buy a Volvo instead. So it's actually with great reluctancy that I accepted to come here, also because I need to debate with Jupp Lange, that I have respected for most of my professional career, and therefore I hate to do this to you, but you'll take it as a man, I'm sure. Let me first start off by declaring conflicts of interest. First of all, I'm the co-PI of the START study examining the risk-benefit ratio of use of early ART. Secondly, I'm a clinician performing practice, see quite a number of HIV patients, and I'm guided by the principle of evidence should precede belief / expert opinion, and therefore lack of evidence should result in uncertainty, which should result in an impetus to generate the evidence to reduce the uncertainty. And then finally, I'm guided in my practice by the theme of first, do no harm. First, do no harm, primum non nocere, is not a new concept, as you are all aware, I'm sure. Those who have been studying medical ethics, this was developed more than 2,000 years ago. And it essentially means that the doctor should not prescribe medications unless she or he knows that the treatment is unlikely to be harmful. Not that I want to attract your attention to the Nuremberg trials because they were so grotesque, but actually to read the documents that came out of that trial is very informative, and therefore also is the basis for much of the discussion about medical ethics that is taught in medical school nowadays. Coming to the topic, just to make sure we're discussing what is actually the controversy, I first put up what I think is the consensus. Continued substantial forward transmission remains the Achilles heel in overcoming the HIV pandemic. Initiation of ART makes persons less infectious. And finally, that ART is of net benefit to HIV-positive people with HIV-related symptoms or with CD4 cell count less than 350. So I'm not going to debate either of those because I agree with all of them. However, the controversy is whether ART is of net benefit to the asymptomatic HIV-positive person if started at a CD4 cell count of more than 350 CD4 cells. This I will call early ART. You can take your phone, that's okay. This is a very controversial topic. I just put some quotes from a recent publication around the 1st of December last year, where two of my American colleagues were quoted for saying, Mike Sack, a CD4 cell count is an outdated trigger for therapy, a relic for research on earlier antiviral drugs. It's an anachronism, it's old school, it's yesterday. Dr. Gallant also said, nobody I know who is an HIV expert feels it's a bad idea to treat HIV at high CD4 cell counts from a medical as well, which is interesting, from a scientific standpoint. As you are also well aware, there's recent guidelines favoring use of early ART. The US Department of Health and Human Service guidelines was released in March 2012 that argue that early ART is a benefit to the HIV-positive persons, and therefore everybody should be treated. We've just seen the WHO couples HIV testing and counseling guidelines released a couple of days ago. These guidelines recognizes the uncertainty in the risk-benefit ratio from early use of ART for the HIV-positive person. It recommends that ART is offered to prevent transmission in heterosexual couples as long as, and I'm paraphrasing the guidelines, I couldn't see this as explicit as I think it should be, but the HIV-positive person is told that there is no evidence of benefit to his or her health, and there could be harm to his or her health in initiating a treatment in that situation. I also assume, although it hasn't been said in the guidelines, that the person makes the decision and needs to do that autonomously, another fundamental point in medical ethics, and without pressure from his or her partner, nor from the healthcare provider. Now, discussing evidence, the great criteria are often and most usually used for assessing evidence, and certainly by the WHO. I quote from the writing committee of the great criteria: observational studies only yield low quality evidence. In unusual circumstances, these studies can be classified as moderate or even high quality evidence. For example, if the treatment effect is extremely large and consistent across studies. So what do we have in terms of evidence for start ART early in the course of HIV disease? We have 3 observational studies. I won't go into the details. Suffice to say that the effect size is not consistently large. In 2, it was close to 1, and in 1, it was more than 2. And therefore, in the great classification schema, this can be at a C, where A is obviously the best. So it's got to be a C. And one would think that you would want to have a higher evidence level as a basis for a worldwide policy involving millions of persons. And this is also a guiding principle, actually, for the evidence for reduced infectiousness from using ART. We had, over many years, large and consistent effects observed on observational studies that ART was reducing sexual transmission. But the policy statements only moved forward once results from an RCT was actually available, following these guidance quite well. We can all say that we are conflicted. The most recent of the observational studies was published in Annals of Internal Medicine last year, and the editors, which is hardly HIV experts, came to the conclusion that randomized controlled trials are needed to better define the optimal time of initiation of combined antiviral therapy in HIV infection. Of course, the editors can be wrong. On the other hand, they may also give a more unbiased assessment. Now, the START study that Rafael Sadra already yesterday alluded to is ongoing and should hopefully address this question. It takes ART-naive patients with a CD4 cell count of more than 500 and randomized them either starting them at that point in time or defer ART until the CD4 cell drops to around 350 or they develop HIV-related symptoms. It's powered for 4,000 patients, 375 endpoints. Most of them will be what we call serious non-AIDS events, organ diseases and cancers. At the moment, we have 2,300 patients enrolled and plan and expect to complete enrollment by this year. And if the study goes to full completion, it will be finalized in 2015. I think importantly, the study, in order to do this, we had to collect 230 sites from 39 countries, and in doing so, we have involved more than 1,000 experienced HIV clinicians. We are randomizing at the moment between 100 and 125 persons a month, and 400 in 2012. We randomized 4 patients today, according to our website. And therefore, there's clearly clinical equipoise in the clinical research community globally for addressing this question. So it's obviously impossible to predict what the outcome of a randomized trial that is ongoing will be, but let me present to you the case of why START may show net harm from early ART. We expect that the magnitude of risk from experiencing morbidity and mortality in early HIV disease without use of ART is relatively low, in particular among younger people, which obviously is overrepresented among persons with early HIV disease. We project that the treatment effect in START will be relatively modest. In the power calculation of the study, we only expect to see a 29% reduction in clinical disease progression. So if that is low, it will not be that much lower if you put people on treatment. On the other hand, we expect to see a variety of ART-related drug effects on different organ systems. I don't have time to go through this in detail. I only have to say that if the scenario turns out to be correct, and we'll know that within the next 3 years, this will have, of course, major implications for persons already started on ART as prevention. A few other points to make about ART as prevention, and they have been discussed already, so I'll go over them briefly. The first one is the gap between those infected and those on effective treatment, not only in the United States. In Europe, we have only around 20% of the infected people on antiviral treatment, and obviously in resource-limited settings, it's 6.5 million people out of a total of more than 30,000. So that's a huge treatment gap. And I think the important point here is to emphasize that lack of access to ART for those that need ART for their own benefit, there's two principal issues here. The first is that there's a large number of infected, not yet diagnosed people worldwide. And the second one is that there's insufficient healthcare provision for known HIV-positive people, and that is true not only in Africa, but certainly also in the continent that I come from, in Europe. In relation to number one, we have recent WHO guidelines which focus on this, but in terms of the second point, it is unclear what guidance exists to actually resolve this. It makes sense to test populations to identify people with HIV, given that we would expect that the risk behavior when you are diagnosed will change, and this is the heavily quoted meta-analysis from 2005 and that demonstrated a reduction in unprotected anal or vaginal sex after diagnosis of around 60 to 70%. So testing makes a lot of sense to do and do it more extensively and more broadly. The other issue that I think in more general terms that I would like to emphasize is that if we rely too much on ART as prevention, we may see a reversal of behavior to a more risky behavior over time. And certainly in MSM communities, at least in Europe and also I believe elsewhere, we have seen that in the last decade. This is data from the United States as well that would suggest that there is an issue as well for further increases in transmission. And I think as a public health issue, this actually is quite complicated and important to realize, so we don't overemphasize that we just put people on treatment and everything is fixed. Finally, in terms of the documentation for whether ART's prevention actually works, I just want to highlight a table that Alison Rogers put together recently, trying to look at the data on how much of the follow-up in the various studies that has been presented, all of them in heterosexual couples, are actually observed why people were not using condoms. Obviously, using condoms and ART together is expected to synergize each other. And you can calculate that the number of person years observed why people were not using condoms is actually fairly low. And this is further complicated by the fact that there is absolutely no data on condom-less sex among, for example, MSMs. So therefore, we want to make sure that we continue to promote condom use as part of prevention of HIV and not overly emphasizing ART as prevention. So in summary, ART as prevention works and is documented to do so in protection of mother-to-child transmission and heterosexual relationship in combination with condom use for the most part. However, health risk and benefits to individual health is critical to know so that patients can be better guided about whether they want to take ART to reduce their infectiousness. Use of ART early in the course of HIV infection is controversial, meaning we are unsure, uncertain, and an ART is currently underway to clarify this uncertainty. I finally want to acknowledge various people, including Andrew Phillips, Jim Needham, Eileen Dennings, as well as the START co-chairs, Art Babaker and Fred Gordon, and the rest of the protocol team and the Insight Network for their contribution and help. Thank you very much.